And that's what we need to look at. And again, there's very little research out there right now that actually talks about how the genetic information can actually be provided to increase these positive feelings to help with adherence. So let's dig a little bit deeper into the intervention in itself, because as I stated, the idea here is to increase the self-efficacy based off of our clients. But the self-efficacy is on the diet and exercise. They have to feel confident in the decisions that they're making, and they have to be able to see that there's some type of result associated with it. One of the biggest problems we have with people's adherence is that motivation decreases because they're not seeing results fast enough. So what does that tell us? What do we have to take from this? Well, we already know that breast cancer is associated with the diet and exercise. But what was interesting when we did the research was a study that focused specifically on walking a week with women that were diagnosed as breast cancer positive risk. They had an 18% decrease in the risk of their breast cancer. That is a huge statistic. That drops their risk dramatically, a little under 0.25%. So the question is if we can identify these subjects using genomics and genome testing for their risk of breast cancer, can we use this same testing to develop exercise prescriptions and diet specific for the client so we can increase their results and increase their confidence and self-efficacy? That's what we need to find out. And as of right now, currently as it stands, there is no data out there utilizing genomic testing for exercise prescription or dietary manner. And so this is an excellent opportunity for us to use this particular preventative measure to implement into an area that is in high need. So how are we going to do this? How are we proposing we do this? Well, obviously there is a need for us to be able to implement this on a wide scale manner. However, because of the fact that there's so little information out there right now and so little for us to be able to develop this program on, we're really looking at more on the lines of a pilot study. We want to keep it small, short-term, so that we can identify the positive notes to the study and also those areas in which need to be tweaked so we can increase the success of our clients. And so our target population is going to be these first-degree relatives, sisters, mothers, daughters. We want to hit them first because we already know that there is a family history of breast cancer in there. But we're only going to be looking at the ones that have the highest risk. Again, it's a pilot study, so we're not going to include both groups. However, later studies and subsequent times when we do the intervention, we can add the other group. But because BRCA1 manipulation has an 80% likelihood of breast cancer diagnosis, that's the group we felt we needed to target. Now, because of the fact that we are really trying to focus on the exercise and the diet adherence and the effects on the manipulation breast cancer diagnosis, we have opted out to allow any other patients to have any other health issues. So they must have an average or recommended BMI level. They must not be diagnosed with type 2 diabetes, and they need to be overall somewhat healthy. So we're identifying the manipulation in the cell for the breast cancer, but they need to be healthy other than that. They do not need to be exercisers or have healthy diets though. Okay? Just disease-free. So how are we going to access our population? How did we want to go about doing this? The thought was that we would do 150 individuals in the study. The subjects would be recruited from 3 different clinical environments. And the reason we're doing 3 different clinical environments is because each of the different groups will have different intervention. We're trying to make sure that there is no margin of error brought in by having each of the groups discussing their intervention with each other. So we're trying to minimize the threat of the study. We're also going to offer participants compensation for completing this study. And the reason we want to go ahead and offer the compensation is because we'd like for them to complete the study so we can have the data, but it also retains the participants throughout the study. So when there's a monetary reward, they'll stick with us. So, and that thought process is really more towards in line of our control group, which we're getting into now. What our thought was is that we would take these subjects that qualify for the study and we would find 3 groups of 50, 1 in each clinical setting. And each of the 3 groups, randomized, would be assigned the intervention. One group would be getting the information of their diagnosis. You have been identified with the cell manipulation of BRCA1. At that point, we let them go. That is our control group. That is what we have seen through the research, and that's how we're going to measure. Our second group would actually come in. We would give them the diagnosis of the manipulation, but then we would tell them, these are the risk factors associated with it, and if you did a diet and exercise, you can help to decrease. But we would not provide them a diet and exercise. We're going to now allow them the opportunity to take the information we've given them, the cognitive information, and see if they take the time to apply it and move forward. Our third group would be more specific to the intervention that we're hoping to try to implement. And that third group would not just get the diagnosis, but we would also then have them develop a personalized exercise prescription and diet based off of their genome testing for muscle fiber type as well as metabolism type. So they would have the complete intervention. Now, the ones with the specific exercise program and dietary program, this group would meet with us monthly. We would continue working with them. The second group that just got the very general information, this group, we would meet with them bi-monthly, just to check on them, see how they're doing. The following group would meet with us at the very end. We would not meet with them at all. They're our control. So we would just ask, what have you been doing? So the thought is, how are we going to approach our measurements? How will we do this? Well, we've got 3 hospitals that have agreed to go ahead and allow us access to their breast cancer patients. And so we are going to ask their siblings, their first-degree relatives, if they're interested in this genome testing. Do you want to be tested for the manipulation of the BRCA1? If they agree to the testing, we will then offer them the testing at no cost to them. In addition to that, every single individual will also be tested for muscle fiber type, so we can determine the type of exercise prescription that we can actually provide to them on an individual basis. The final testing that each of the individuals will receive at no cost to them is their metabolism hormones. We want to ensure that their metabolism hormones are functioning properly, and more importantly, we can then develop programs, dietary recommendations that would be best fit for their metabolism type. At that point, each of the participants who have been accepted into the study would be asked to complete an exercise questionnaire. How much do you exercise at this point in time? As well as a dietary questionnaire. What does your typical diet look like? How many calories do you take in? Do you do a lot of carbs? Do you eat out a lot? We would also then ask them to fill out an exercise and diet self-efficacy survey. How confident are you in this? And then we'll ask them to fill out the health history questionnaire, because this health history questionnaire is going to help us to identify if they've ever had past health issues, which then allows us to either remove them from the study or keep them in the study. At this point, this is where we will be able to identify the subjects that will be brought into this study. We'll know whether or not they are mainly healthy. We will also know their self-efficacy levels for exercise and diet. We'll know what their metabolism is. We'll know what their muscle type fibers are, and we'll identify whether or not they have the manipulation of the gene. So again, our thought is for the intervention, it's a 6-month study. We won't go past the 6th month. It's a pilot run. Our first group, again, would be meeting with us through the weeks. Our second group would meet every other, and finally would not meet at all. However, at the end of the 6 months, each group would then be asked to complete the range of surveys again. We would ask them, please complete your exercise survey. How often do you participate in exercise? Please complete your dietary survey. What does your diet currently look like? Complete your self-efficacy survey. And now let's look at your health history questionnaire. And the reason we're going to ask for the health history questionnaire is because this gives us further information if they've done any additional research on family health during this time of the 6th month, which may be something we can use later on in further studies. So our goal is to measure pre and post to exercise adherence. Is there a change into the exercise adherence, and which group happens to have the highest rate of exercise adherence and change for that? Is there a change in dietary behaviors? We'll look at pre and post, and primarily which group would have the highest rate of change for dietary behaviors pre and post. We're also going to measure the differences between the pre and post self-efficacy for the exercise and diets, and really look at which group has that significant change. And then we want to make sure that when we look at this, the interventions that we've implemented have had those significant changes for each of the surveys. So our goal is to look at those at pre and post levels.
Right.
And this is where I'm going to hand it off to my partner.
All right. So again, thank you, Heather. We have a couple main hypotheses here. We want to make sure that those individuals that are identified with the BRCA1, we want to help them increase their participation within healthy behaviors, changing their lifestyles, making sure that we can help decrease those risks. Because, as Heather mentioned earlier, just walking a minimum of a mile or an hour and a half a week can decrease your breast cancer risk by 18%. Also, utilizing the genome information, okay, to develop that healthy exercise prescription, dietary plan, program. Each of the groups are different, as she mentioned. One group is going to get a full-out, detailed assessment where we're going to look at all of their, diet and exercise prescription. The other group, again, is going to get a